Welcome to this presentation on lab departments and common tests for the blood bank or TML department, hematology, coagulation, and surgical pathology departments, also covering specimen integrity. In this session, you'll learn about some of the departments in the clinical laboratory. This includes blood bank, otherwise known as TML or transfusion medicine, hematology and coagulation, and the different areas of the anatomic and surgical pathology department. You'll be able to identify common tests and sample types associated with each of these departments, and be able to describe the special requirements for collecting specimens for blood bank or TML. Finally, you'll learn about the various ways that specimen integrity can be compromised. Here's a list of topics we'll be covering and the slides on which you'll find the details and descriptions. We'll talk about the blood group systems, the blood bank or transfusion medicine department, the hematology department and its subsection coagulation, and the histology and pathology departments. We'll also discuss specimen integrity and have a brief introduction into the order of draw, or the order in which tubes should be drawn. It looks like some pretty interesting information about lab departments. Let's go find out more. Whoa! We'll start with some fun facts about blood before taking a closer glimpse into the blood bank department. The average adult has 5 to 6 liters of blood volume based on their weight. 55% of whole blood is composed of plasma, and the other 45% is made up of formed elements: red blood cells, white blood cells, and platelets. You can see that red blood cells take up the largest portion by far of blood cells, with white blood cells and platelets making only a thin layer called the buffy coat. You should be very familiar with this diagram, hint hint. Blood donations used in transfusions is made by very generous donors every day. In TML, a unit of blood is a common term for 450 to 500 ml bag of whole blood. Once the blood is collected in a blood donation center, it's sent off to be tested for blood type A, B, AB, and O, and also for infectious diseases that could be transmitted, like HIV and hepatitis. Whole blood is rarely ever transfused. Instead, it's centrifuged and separated into various transfusion products. For this to happen, the blood must not be allowed to clot, so bags contain the anticoagulant CPD, or citrate phosphate dextrose. Did you know? Over 1.5 million units of blood are transfused in Canada every year. That's a lot of blood. ABO and RH are blood group systems that are determined by inherited antigens on the surface of the red blood cell, so it comes from your biological parents. The ABO system is unique in that the body automatically produces antibodies to the opposite ABO blood group. For instance, if you inherit the A antigen, your blood type A, and your body automatically produces anti-B antibodies. The RH blood group system does not have this automatic antibody response, but if an RH negative person has been exposed to RH positive antigens through childbirth or transfusion, let's say, they may produce RH antibodies. Here's an A&P refresher. An antigen is a substance that causes the formation of antibodies. It could be either an inherited antigen on the surface of a cell or a foreign substance like a bacteria or a virus. An antibody is a protein substance manufactured by the body and directed against an antigen. If you look at this chart, you can see that group A blood has A antigens on the surface of the red blood cell, represented as purple circles, and anti-B antibodies are automatically produced. Group B blood has B antigens, shown as green diamonds, and anti-A antibodies are made. And in blood group AB, both A and B antigens are present on the red blood cell surface, but no antibodies are made. Group O is the opposite. There are no antigens present on the surface of the red blood cell, so both antibodies are automatically produced. If a type A person is mistakenly transfused with type B blood, the patient's anti-B antibodies will attack the antigen on the group B cells and destroy them. This is called a transfusion reaction, and this mistake could have fatal consequences. This brings us to the purpose of the next lab department we'll be discussing, which is the blood bank, or immunohematology, or transfusion medicine lab. These are all the same department, just 3 different names. This department prepares blood products to be used for blood transfusions. The procedure performed in this lab involves collecting, storing, and processing blood, and the distribution of red blood cells and blood components. Examples of blood components include packed red blood cells, platelets, fresh frozen plasma, and cryoprecipitates, which consists of different clotting factors used to treat hemophiliac patients who lack specific factors. Blood samples for transfusion must be tested for compatibility prior to transfusion being administered to avoid incompatibility and transfusion reactions we just talked about. Transfusing the wrong blood type into a patient can result in patient antibodies attacking the donor's red blood cells, which leads to hemolysis or red blood cell destruction, and even to death. Plasma and red blood cells are used to perform the testing in the TML department, and the tube of choice is the 6 ml EDTA tube, which is purple or lavender in color, as seen in the photo, along with the unit of O-positive packed red blood cells. The main tests that are performed in the TML department are ABO and RH grouping, group and screen to pre-screen for atypical antibodies, and cross-match to prepare blood products for transfusions. ABO and RH grouping, or typing, is performed on all donated blood. It's also used to screen pregnant women for RH compatibility with her baby. An RH negative mom may produce RH antibodies if she's carrying an RH positive baby. To prevent this, she needs to be administered RhoGAM, which is an immune globulin that inhibits antibody production, so her antibodies don't harm her future RH positive babies. ABO and RH typing is also performed to screen patients or donors, not just for blood transfusions, but also for those who are potential candidates for transplants, such as organ, tissue, or bone marrow. Another test performed in the TML department is the group and screen, which types ABO and RH and also screens for possible unexpected antibodies that may pose a risk during transfusions. The purpose of a full cross-match is to mix donor and recipient blood and look for reactions to test compatibility or suitability of the blood for transfusion before it is transfused. The testing also includes ABO and RH and antibody screen. Conditions or situations that may warrant a transfusion include severe anemia and conditions causing anemia, such as sickle cell disease and thalassemia, excessive blood loss, such as injury or trauma, or bleeding during or after surgery, and medical conditions that result in blood loss, cancer and the effects of chemotherapy, and bleeding disorders, such as hemophilia. MLAs are responsible for collecting blood specimens for the TML department, and there are special patient ID procedures in place for collecting TML tests, such as group and screen or cross-match, to ensure there are no errors in patient ID. In addition to the 3 standard patient identifiers, full name, date of birth, and hospital ID, and the 3 pieces of label info, date and time of collection, and your initials, you must make the added step of handwriting the patient's unique hospital ID directly from the patient's armband onto the tube label, and it must match exactly, letter for letter, number for number. Why is this important? This is vitally important to ensure the blood specimens for TML are properly identified with that one person only, to ensure that the correct patient is receiving the cross-matched compatible blood. If there are errors in patient ID, the transfused blood can agglutinate and hemolyze, causing a transfusion reaction leading to organ failure, which can potentially be fatal. In the photo, you can see that the MLA has handwritten the unique hospital ID onto the TML tube and is double-checking for accuracy. If the unique hospital ID is not written on the TML tube, or it's written incorrectly, the tube will be rejected when it gets delivered to the lab, and this will need to be recollected, causing delays in testing when often cross-matches need to be stat. As the armband below asks, do you carry the responsibility for any loss of life due to errors in patient ID? It's pretty serious. Let's take a look at another department and see what they do there. Let's take a look at the hematology department. Here they analyze tests to identify diseases of blood and blood-forming tissue, diseases such as anemia, or blood cancers such as leukemia and lymphoma. A complete blood count, CBC or hematology profile, is by far the most common test done in this department and is used to evaluate your overall health. It's an automated test, which means it's run on an analyzer. The CBC counts the number of red blood cells, white blood cells, and platelets in the blood, measures hemoglobin amounts, and determines hematocrit, or the percentage of red blood cells in whole blood. The sample type is whole blood, since the analyzer counts each of the different types of cells one by one. The tube of choice for the CBC test is the 4 ml EDTA tube, which is purple or lavender, as seen in the photo, along with the hematology analyzer loaded with samples waiting to be tested for CBC. Any small clumps containing multiple cells will be counted as one cell and will skew the results. Therefore, the EDTA anticoagulant must be mixed with the blood immediately to avoid microclots happening. Tubes containing microclots will be rejected when they're delivered to the lab and will need to be recollected. From the collected CBC tube, an MLA may be asked to prepare a thick or a thin blood film so the lab technologist can perform some manual tests. Thick blood smears are most useful for detecting the presence of malaria parasites, since these blood parasites are present in low numbers, and a large sampling of blood can be analyzed with a thicker smear. A thin blood smear is a drop of blood spread across a large area of the slide to create a single layer of cells that allows the technologist to see each cell individually during the microscopic examination of blood. They can count percentages of white blood cells and look at morphology to detect abnormalities in the appearance of blood cells. This is a useful diagnostic tool for differentiating blood diseases. The coagulation department is usually a subsection of hematology and studies the ability of blood to form and dissolve clots. Tests in this department are used to diagnose and monitor defects in the hemostatic or blood clotting mechanism, such as bleeding and clotting disorders. This department also monitors patients who are on anticoagulant therapy, such as Coumadin or warfarin, that is prescribed to prevent the formation of blood clots, or thrombi and emboli, in conditions such as deep vein thrombosis, or DVT, stroke or cardiovascular accident, heart attack or myocardial infarction, or pulmonary emboli, PE. A thrombus is a stationary blood clot within a blood vessel that impedes blood flow. An embolus is a blood clot that has broken free and is circulating within the bloodstream. The main tests are PT-INR, APTT, D-dimer, fibrinogen, and thrombin time, and we'll cover these in more detail on the next slide. Tests in this department are mainly performed on plasma, and the tube of choice is the light blue colored sodium citrate tube. These tubes must be completely filled to a 9:1 ratio, as we'll discuss in more detail soon. I briefly mentioned the main coagulation tests, but let's cover them in a bit more detail. Prothrombin time, PT, is a common coag test which measures blood clot formation time, and international normalized ratio, INR, is a calculation based on the PT result that is standard regardless of metric or imperial units. The PT-INR test monitors Coumadin or warfarin anticoagulant therapy, or it is used to evaluate bleeding bleeding abnormalities in the extrinsic coagulation pathway. Partial thromboplastin time, PT or APTT, is another common coag test that monitors heparin therapy, which is a different kind of anticoagulant or blood thinner. And the test also used to screen bleeding abnormalities in the intrinsic coagulation pathway. D-dimer is a protein fragment made during fibrinolysis, or the dissolution of blood clots in the body. So the test is used to help rule out the presence of inappropriate blood clots, thrombi, and emboli. Some of the conditions that D-dimer test is used to help rule out include deep vein thrombosis, DVT, and pulmonary emboli, PE. Fibrinogen is a protein that is a coagulation factor made by the liver. This test measures fibrinogen levels in the blood for the purpose of diagnosing hemorrhagic disorders or fibrinolysis. Thrombin time measures fibrinogen function, or whether fibrinolytic therapy is working. Abnormal results may be due to inherited fibrinogen disorders, liver disease, or may be caused by certain cancers or medications that affect clotting. As mentioned earlier, the tube of choice in the coagulation department is the light blue sodium citrate tube. Tubes collected for coagulation testing must be filled completely. Tubes have a pre-measured amount of vacuum, precisely measured to fill the tube, and the vacuum is exhausted when the tube is full, so you cannot overfill blood tubes. But if you lose vacuum during a draw, or remove the tube from the holder too soon, the tube will not completely fill with blood. In sodium citrate tubes, there's a liquid anticoagulant, as seen in the bottom of these tubes, that will dilute the coagulation factors in the blood if the tube is underfilled, which will affect the test results. So we must ensure the blood to anticoagulant ratio is 9 parts blood to 1 part anticoagulant. The red arrows on the picture to the right are indicators on the tube showing the minimum fill levels, and if the tube is underfilled, it will be rejected when it's delivered to the lab and will need to be recollected, causing testing delays. Anatomical and surgical pathology, or A&P, is the CSI of lab departments. It's a medical specialty concerned with the diagnosis of diseases based on the examination of organs and tissues. This is done by a pathologist by macroscopic and microscopic examination and biochemical, immunologic, and molecular testing. 3 areas of the A&P department are histology, which is the study of tissues at the microscopic level to detect abnormalities in the structure or function of tissues or organs. Cytology is the study of cells at the microscopic level to diagnose malignancies. Cytogenetics, or molecular genetics, identifies changes in chromosomes, genes, or proteins to rule out a suspected genetic condition or determine a person's chance of developing a genetic disorder. And sample types in these departments include tissue samples from medical procedures, biopsies, surgeries, or autopsies. So it's not just tissues from live patients we're talking about. Usually, pathology specimens are collected by doctors or pathologists. If they're received in the general lab, as an MLA, you may be responsible for dispatching them to the pathology department. Once there, the samples are usually accessioned by clinical assistants who work exclusively in the pathology department. Then they are processed by technologists and interpreted by a pathologist. Now let's discuss a little about the quality of the samples we collect. Sample integrity is crucial. We want to ensure all samples are collected at the proper collection time and that we're strictly adhering to the established collection protocols to collect quality samples and avoid any collection errors. Patient care is often based on test results from specimens assumed to have been collected correctly. If there is a problem with sample integrity, then test results are meaningless, and the patient could be misdiagnosed or receive inappropriate treatment for their condition. This can result in patients experiencing lost treatment time and cause anxiety. In addition, it can cause the patient, their family, the nursing staff, and the doctor to to lose faith in the expertise in the laboratory. Pre-analytical errors are errors that happen before testing, and as you can see from the stats below, this makes up a large percentage of the total errors in the lab. As an MLA, this is our domain. Look at the list and see how many ways the sample quality can be impacted by pre-analytical errors. It is our job to follow collection instructions and ensure correct sample handling, so we have a lot of responsibility. You can see that errors occur due to patient ID error, patient preparation error, tube mislabeling error, sample collection errors, and incorrect handling of samples or transport errors such as sample delays. For instance, if a therapeutic drug level is drawn at the incorrect time, the patient doses may be adjusted based on erroneous results. If a doctor requests a fasting specimen on a patient and the MLA did not confirm the diet restrictions with the patient, the test results will be affected and misdiagnosis may occur. We've discussed collection techniques such as correct labeling of samples, especially tubes for the blood bank department, but all labeling is important. We've discussed avoiding microclots in hematology samples by mixing the EDTA tube immediately. And we discussed filling the sodium citrate tube completely to a 9:1 ratio for coagulation samples to avoid dilutional errors. All of these errors can affect test results and can be avoided by the MLA using proper technique and sample handling. In addition to sample collection and handling errors, the sample can also be affected by contamination, which can occur from alcohol residue, glove powder, baby powder, or fingerprints. Glove powder on slides or in capillary specimens can result in misinterpretation. Unwittingly dripping sweat into capillary specimens during collection or processing. Salt from sweat would affect the sodium and chloride levels in the sample. Touching a site after it's been cleaned with antiseptic. Not cleaning the site adequately, especially during blood culture collections where skin flora can contaminate the bottles. Collecting a sample before the alcohol is dry can cause RBC destruction. Using the wrong antiseptic to clean the site prior to collection can also lead to specimen contamination. For example, for an ETOH or ethanol level, using 70% isopropyl alcohol would falsely increase the ethanol level in the sample. Another example is not using chlorhexidine gluconate or iodine to clean a site that could result in contamination of blood cultures. Or collecting blood tubes in the incorrect order of draw. What is the order of draw, you ask? Order of draw refers to the special sequence in which tubes are collected during a multiple tube draw. Filling tubes in the wrong order can result in a carryover of additives that are in the tube. So the additive from one tube can contaminate the next tube that's collected, unless they're collected in the correct order of draw. Wrong collection order can lead to cross-contamination of the specimen, which interferes in testing. Order of draw may vary slightly among institutions, so always follow your facility policy. Following the recommended order of draw is very important for specimen integrity. This is the order of draw chart used in Fraser Health, and this is what we'll be following at Stenberg College. Please familiarize yourself with this, as it will be very important throughout this course. This slide shows the order of draw once again. It also has some more detailed information about the minimum draws for all of the tubes. Minimum draws refers to the minimum amount of blood that is required in each tube to accurately perform testing. If the tubes are underfilled below this level, there will not be enough sample to run the test and it will be rejected by the lab, so it will need to be recollected. Please note the 4 tubes on the list that require a full draw. The sodium citrate tube, light blue, the ESR tube at number 13, the black charcoal tube, the ACD tube at number 14, and the NIPT tube at number 16. These all require full draws. Please take a moment to review the following concept questions. Question 1. An individual's blood type is determined by the presence or absence of a certain type of A. Antibody present on the white blood cells. B. Antibody present on the red blood cells. C. Antigen present on the white blood cells. Or D. Antigen present on the red blood cells. Question 2. A blood clot circulating in the bloodstream is called a or an A. Aneurysm. B. Thrombus. C. Embolus. Or D. Fibrin. Question 3. The area of the lab that performs tests that identify diseases of blood and blood-forming tissues is A. Hematology. B. Coagulation. C. Microbiology. Or D. Cytology. Question 4. Proper patient identification means A. Asking a second person to verify your ID procedure. B. Actively involving patients in their own ID. C. Checking the requisition against the patient's room number. Or D. Scanning the patient ID bands with barcode readers only. The answers are 1. An individual's blood type is determined by the presence or absence of a certain type of. The answer is D. Antigen present on red blood cells. Know the difference between antigens and antibodies, and that blood group antigens are found on red blood cells, not white blood cells. 2. A blood clot circulating in the bloodstream is called a or an. The answer is C. Embolus, which is a circulating blood clot. A. Aneurysm is a bulging or weakening in the artery. B. Thrombus is a stationary blood clot within the blood vessel. And C. Fibrin is a thread-like substance that helps clots form. Question 3. The area of the lab that performs tests that identify diseases of blood and blood-forming tissue is? The answer is A. Hematology. Question 4. Proper patient identification means B. Actively involving patients in their own ID, as per CLSI standards. In A, asking a second person to verify your ID procedure, no, you should be IDing it well enough on your own. In C, checking the requisition against the patient's room number, no, we never use the patient's room number to identify the patient. And in D, scanning the patient ID bands with barcode readers only, no, the patient must also state their first name and last name and state their date of birth. Question 5. List 3 important pieces of information you need to verify when identifying a patient. The answer is 1. The patient must spell their first and last name. 2. The patient must state their date of birth. And 3. You need to compare the PHN or hospital ID number to the requisition. Question 6. List 3 other important pieces of information you need to add when labeling the sample after it has been drawn. The answer is date of collection, time of collection, and your collector initials, so they knew who drew the sample. Question 7. What is the added step you must make when labeling samples for blood bank or TML? The answer is that you must handwrite the patient's unique hospital number from the patient's armband onto the tube exactly, letter for letter, number for number, before leaving the patient's bedside. In summary, these are the lab departments we toured today: Hematology and the subsection Coagulation, Blood Bank or TML, and the anatomic pathology areas. We learned some of the tests associated with each of these departments and the sample and tube types, and special ID procedures that an MLA must know when collecting samples. We also learned about pre-analytical errors and the various ways an MLA can adversely impact specimen quality. Finally, we had a brief introduction to the concept of the correct collection order when drawing several tubes at once, called the order of draw. In the chart, you can see these departments highlighted, showing what they evaluate, some tests performed there, and sample types and special collecting precautions. It's been my honor leading you through this guided tour. Thank you. That brings us to the end of this presentation.